So our first session is regarding the barriers and facilitators to introducing digital therapies into the NHS. And I'd like to welcome to the stage Dame Till Wykes, Professor and Head of School at King's College London, Johnny Downs of NIHR, Clinical Scientist and Clinical Senior Lecturer, and my great friend Liz Ashall-payne, who's come all the way down from the fabulous northwest of England, who's Chief Executive Officer of ORCHA. If you'd like to come to the stage, I'm going to hand over to you now. And we'll be on hand to take questions and pass the mic.
Okay, you might have noticed that Maria isn't here. So we've had all sorts of issues with transport, but also winter problems, winter viruses in particular. So Maria isn't able to come because she's got something from her kids. So we're missing one part of our talk, because I'm going to just mention a technology product that I developed with colleagues at King's College London, it is a sort of therapist-supported digital health product, still within the university. I'm going to talk a bit about how the NHS, we can facilitate getting these sorts of products into the NHS. Johnny here is going to talk about the way that digital products can help. CAMS, obviously something that everybody has heard about in the news media. And of course, Liz is going to talk about the non-regulation but interesting evaluation of digital health products. So I had quite a busy weekend, so my notes were made, and I'm going to move out the way of this very bright, thank you, very bright light. One of the things that I wanted to talk about was, you all know that this government and the next is likely to be thinking that digital health products are something that they really want to embed into the NHS. They have promised for reducing waiting lists potentially, but they also have promised in maintaining people's mental health in particular. And we know that if people have a physical health problem and a mental health problem, then they use far more NHS services for their physical health problem. So those people with depression who have a heart attack and then develop symptoms of depression are more likely to have a second heart attack. People with arthritis who have depression also are more debilitated and have a poorer quality of life because they have mental health problems. So what we really want to do is to think about how there is a relationship between mental and physical health and try and fix some of the problems both for the physical and for the mental. But the title of this is Facilitators and Barriers in the NHS. So despite political will, we need to really understand the will for the regulators and for NHS providers. There's been quite a lot of talk, actually, this weekend from the shadow NHS spokesman about the way that these services could be organised. But this is one of the problems that we have about the NHS, is that it's perpetually being reorganised. So we end up having to work out which person we talk to about the potential for digital health products. So for me, I have a product called Circuits, a therapist-supported service that needs the therapist for the more supported needs for people with severe mental health problems. We've done just about everything. We have trial data coming out of our ears. We've got feasibility data. It was co-developed with the people who will be using the therapy. That's important because we don't want to roll out therapy when we have stakeholders who are just, for instance, people who've got transitory depression symptoms are often the people who are the test bed for some of the apps that are currently in the app stores, when actually you don't want necessarily to roll them out to people who are actually diagnosed with depression, particularly chronic depression. So my therapy my digital service is to create something which can be used in the NHS, so it's seeded across the NHS in lots of trials. But it turns out that people in Australia, people in New Zealand, people in Finland, in fact, all outpatient services have access to circuits, the digital therapy, but that is not the case in the UK. So why is that not the case? I think partly it's because the recognition, I've done studies on what are the facilitators and barriers. So staff particularly say they need to know about the clinical need and they need to know about the effects of the therapy, but they also need to know whether they've got the resources and the time. So we need probably, as people developing services, some more cost effectiveness data, because clearly that is what NICE and all NHS providers are interested in. What patients want is a potential therapy which doesn't preclude them from actually getting access to NHS services. So I think what we need to think about is a streamlined service. We need evidence. We need evidence of benefits. We need what I've written about called transparency for trust principles. So we need to have information on privacy and security. Some of the DTAC regulations actually allow that to be evaluated. We need to know how it's developed, because we need to know it's been developed with the population of people who it's going to be rolled out to. We need to know what the benefits are, and we need to know whether it's feasible. And feasible means, does this app actually get used for more than a couple of weeks? Because mostly the data on outcomes that shows that it works means that somebody's has used it for 2 weeks. Most people who download an app, you're probably all in the audience, only potentially download it once and tend not to download it any other time. So those 4 principles, privacy and security, development characteristics, benefits, and whether the development was with the right group of people, are transparency for trust principles, and they really ought to be available into the NHS for both the patients and the therapists and the services, so that we know that this is a therapy that is likely to be of benefit. What my example is, if you go into Tesco's and you look for a box of cornflakes, you can turn the box round and you can see what the ingredients are. If you go to an app store, most of those ingredients are completely absent or written in a language which no one understands. So we really need that information to be available to everybody, including the patients themselves. I've been waved at because I've gone on for 7 minutes, which was a surprise to me. And I'm going to hand over to Johnny, who's going to talk more about NHS systems and the barriers and facilitators.
Thanks, Till. Thank you. So I'll pick up on some of the points that you've made, really, but maybe focusing, can I just get a sense of, so who would classify themselves as being from industry in related to mental health? Just a quick show of hands, that would be really helpful. And then who would classify themselves as actually being sort of squarely footed within NHS, either provision or commissioning? So there's a kind of brave, okay, so a mixed bag. So I'll try and talk to all. And who's just a clinician that's just interested in saying what else is going on within the health tech sector? A few of those, okay, great. So my name's Johnny Downs. I lead the CAMS Digital Lab, which is an academic health collaboration between the Maudsley or King's Maudsley Partnership, based in South London, but we also provide services for other parts of the UK too. And what I'm going to basically try and talk a little bit about is this idea of value proposition, and how do you make a value proposition, if you're developing a product within services, so trying to kind of tell your business managers, as it were, about why it's worth giving you the time and maybe a little bit of cash to get things going, but also if you're developing or have developed a product and you're trying to sell into the NHS and trying to sell and couple or develop collaborations with providers, what do you sort of really need to do? What the organizing principles for any change at the moment are around equity and around access. And then with that, obviously, it's good to have evidence of effectiveness and have some economics behind it. Can you demonstrate that you are going to be a return on investment? And that return on investment could be obviously time, and principally we're organized, I'm thinking about within clinical services, we are really interested in things that save time. If you show a product, even if it demonstrates an evidence-based of improving diagnostic accuracy by a certain amount, if it's related to actually an adjunctive bit of therapy that you're adding onto a blended care model, if it's not looking like it can save time, then it's going to be problematic from any commissioners within our services. One of the reasons why it's problematic is because the implementers, and they're often ignored, the implementers are crucial in this. So even if you get sign-up and you get expressions in principle and you get a bit of seed funding and pilot funding, if you don't have implementers on board, if you don't have them guiding probably from the product side and also from the sort of essentially the collaborator side, if you don't have good implementers that are guiding how you're going to get your product into a particular care pathway, it's going to fail. And I speak from experience. I'm expert at failing with getting digital products implemented and delivered within care pathways. So be minded when you're making a pitch for your product, it's got to really tick those boxes. Obviously, it's got to go through all of those technical requirements, all of the sort of, the privacy requirements. It's great if you've got some robust evidence of effectiveness. Sometimes that's not quite needed as much as some people want. It depends who you're selling to. If you've got grim-faced only academics that are having their idea of what effectiveness is versus someone that's maybe a little more practical and knows what essentially what's happening in the control group, as it were, and can still see benefits, you might not need quite the levels of evidence that one might assume that we need from drug industry, etc. But the kind of crucial aspect is to have that sort of element of patience. As Till has pointed out, Till's been developing products since, don't say, but a long time. If you don't have patient capital, and if you don't have a business model that can accept the fact you're going to need to talk to people endlessly, repetitively, having the same conversations with different people from the provider side, you're going to really struggle to gain traction. One of the things that we develop products, very simple things, and I first started having proper conversations about them in 2015, 2016 within my own organization. And I also have a procurement budget as well. Within my organization, it took 5 years to actually get a product scaled within our services across 27 sites. It's that sort of patient delivery of moving and shifting with the demands. There wasn't the same concerns about access at that point. There now is. So you then have to be able to move and shift your project. The other thing is also being able to demonstrate you are a trusted partner, and that only comes with time. Trust is not automatically delivered. So again, my understanding from even if you're selling or developing your products within NHS organisations, you've got to stay the course and got to keep staying the course. We've got to bring in implementers. I'd really recommend, if anyone hasn't read it, is Recoding America by Jennifer Polka, who really, really makes an excellent case about how the implementers are the key drivers to actually ensuring that change happens. And because actually all of these health products are around sort of changing behaviors, the product itself is a bit secondary. It's actually changing patterns and practice of behaviors to make them more efficient, deliver better care. I'm going to leave, am I allowed to keep blabbing on for one more minute? One key aspect, and what is really convincing for us, is if you've done user acceptance testing in the types of population that we serve. What is a little bit frustrating for us is when we realize that products have been migrated from other parts of the world or have been tested in sort of quite niche academic settings. I'm guilty of that too, where we don't really show that they have evidence of actually delivery within the majority population that we work with. So it's just also being able to say that you've done some pilot work, you've actually seen what the product looks like, maybe not completely regionally where we are, but something that has a population mix similar and has population needs and demands. My final bit is just to speak about Maria's work as well, because I think it's really important to just mention the work that she's done. I've very much focused on the clinical end of things, where Maria has basically been working on single-site interventions and the potency of those single-site interventions. I feel that that is a real winner. What that will provide us, when the evidence is mounting, is the capability to rapidly treat and triage people when they have had their needs identified early. But it's doing it in a way which is sufficiently light touch to know that it is scalable. So if I can urge you to have a quick look at Maria and Jennifer Shriver's work in single-site interventions, I think that's crucial as well. If you can provide a product, my final piece is, if you can provide a product and partner with a provider rather than be standalone, you are probably more likely to get traction with ICSs. My experience is that ICSs and ICBs really struggle with having multiple different contracts from different parts of the piece within their estate. If you can demonstrate you can deliver a product via a major provider of those health services, you are much more likely to then have long engaged, sustained contractual support and funding. So I think that's my piece. Thank you.
Okay, so thank you so much for letting me join today's panel. As was introduced, my name is Liz Ashall-payne and I'm the founding Chief Exec at ORCHA. As Shane shared with you, I'm also Vice Chair for the Health and Social Care Council at Tech UK, and I'm also on the Board of Directors at Tech UK representing SMEs, not just in healthcare, but across all verticals. Having said all of that, my background in industry, my actual background is clinical. So I worked in the NHS for over 20 years, starting life as a clinician, working in complex paediatric care. So how did I get here? Well, I got here because I started to feel that as a clinician, I could only see one patient at a time. And I knew that there were hundreds and thousands of patients who needed access to my healthcare and the knowledge that I knew. And that became my driving passion. And when I saw the rise of digital health and smartphone devices, I thought, this is it. This is the answer. We just need to give everybody an incredible, safe, effective digital health tool, and everybody can have access to healthcare. But it's not that simple. So I have been, it's been nearly 9 years since I founded ORCHA, and we continue to try and deal with some of the barriers that are out there. And before I get onto the barriers, what I wanted to do was start by talking about the opportunity that we have here. So I mentioned that we all have these smartphones. We currently have more smartphones on the planet than we have toilets or toothbrushes. And what that tells us is that our populations have bought the infrastructure to use technology. What we also know is that there's over 350,000 digital health apps or web-based technologies. In the world of mental health, there's about 21,000. It's a huge opportunity. And every day, 5 million people will download a health app. Healthcare professionals think these technologies could help their patients, so why have we not embraced them? Well, unfortunately, our research has found that only 20% of all the technologies out there are safe and effective. And what that means is for most people who are downloading a digital health technology to support them or their family member, they're downloading something that isn't even safe, potentially not regulated, which means that a lot of people are finding non-useful interventions. And why do I care so much? Well, there's a missed opportunity, because if we could get the great technologies, of which we've heard about a few, to those people, those technologies could have a positive impact on people's lives. So in my quest to try and break down the barriers, I've been obsessed with 5 key barriers. The first barrier, and I've mentioned one actually, the one that I mentioned is trust, and that is the biggest barrier. However, before trust, the first barrier is awareness. Healthcare professionals and healthcare systems are not aware that these technologies exist. And that's because we're not trained in them. I saw a piece in the Times yesterday saying that doctors and nurses were resisting technology in the NHS, and that's just not true. Professionals want to use these technologies, but we don't know which technologies to use, which ones we can trust, or how to deploy them. And so that awareness has to be dealt head on with education and training, and I'm such an advocate of that. The second barrier is once you become aware that these technologies exist, where do you go to access them? And you may say go to the Apple App Store or Google Play and have a go, type in mental health. And I can tell you now, you will not get the 21,000 that I just mentioned. Type in a word like depression or suicide, and you'll get a couple, but you will not even be able to access the full list, let alone a specific technology for your personal preferences and needs, or your patient's personal preferences and needs. So access is a real problem. Once you've accessed these technologies, your next challenge is trust. How do I know if it's safe, effective, data private, data secure, has been tested with end users? How can I trust this technology? The fourth barrier, particularly for the healthcare professionals out there, is once you feel that you can trust a technology, you then think, okay, I want to recommend this or signpost it to my patients. And let me tell you, waving your phone at a patient is not a safe clinical system. Because if you wave your phone at a patient and say, go and use app ABC, the patient could leave, think, did she say app ABE? Or get the wrong product. It's akin to waving a packet of drugs at a patient and saying, go and buy these drugs. So we need to have a governance system that allows us to track and know what technologies have gone where. And of course, the critical bit here is who's going to pay for that technology. Because I know I don't want to recommend or signpost a paid for technology to my patient. We work in the NHS. So who's going to pay for these technologies? And I think that that's quite a thorny challenge. But what I want to really alert everybody to is to really think about these technologies as interventions. Once you know it provides clinical evidence and that return on investment, we should be paying for these products. And the reason we should be paying for these products is because huge amounts of investment goes into developing them. So Johnny talked about some products that he's invested, and it took him 5 years. We have to be able to show the people who invest in these technologies that there is eventually going to be a return on investment. But of course, that has to be linked to the quality and effectiveness of that tool. And the final thing I just wanted to say is this is not about single point solutions. There is no one best mental health product out there. It depends on the person who's presenting, their demographic profile, their cultural background, their technology preference. And so what we need is a range of technologies across a pathway for different people in the same way we have with drugs. And actually, that's when we're going to see the true return on investment for digital health interventions. It will be a pathway. I'll hand back to the chair.
Okay, I am now on. I was great from both of you. I think one of the things I'll just pick up on before I go out to the audience is this issue of effectiveness. When we're doing academic studies, we say something's effective because it's, the chance of showing a small improvement is very, very small. What we really need to get to with these products is to say how many people out of 10 might this product actually improve. So one of the difficulties about presenting any therapy is you need to present it in context. Because if only 5 people out of 10 are likely to improve, then the person actually receiving that digital therapy needs to know that. And the reason they need to know that is because of the way that Johnny and I both work in the health service, is that if they fail to improve after receiving this digital therapy, it won't make them feel much worse than they did before they started. Because they will just be able to think, while I was one of the 5 other people who didn't actually improve with that therapy. So I think it's for us, for people like Johnny and I who are doing multi-centered studies of these digital therapies, to be able to make it simple, which I think ORCHA is leading to, make it simple, the information that we present to people, and make sure it's in context so that you don't think that you're going to win when actually you're not. Okay, well, this is a sort of conversation, so...
Can I follow on from that?
Sure, yeah.
So what's kind of crucial is actually interoperability. Because if you can just show, and this is the difficult with a lot of the digital products that kind of come and go, is that I often can't find when they've been used in my services. Even if they've been recommended by a particular therapist, I don't know, A, whether a patient has properly engaged in them, what types of patients are engaging in them, and then when they stop. And I can't find that in my healthcare record because of an interoperability gap. So I don't even know whether someone's done better or recovered. I can't then make a business case for then saying, actually, 4 out of the 10 patients, it reduced the time, and 4 out of 10 patients did recover, did do well under the program. So we can then funnel a little bit more resources towards those 6 out of 10 that don't do so well, but we can actually be fairly confident that a proportion will maybe need less human resources in order to be able to deliver the therapy. So if you could think a little bit about how you may interface with your providers' EHRs, that is gold from a clinical side.
Thank you. So just on the evidence piece, I just wanted to share with you something that you may want to go and have a read up on, which is the NICE Evidence Standard Framework. And the NICE Evidence Standard Framework is all about assessing a proportionate approach to a digital health technology. So at the top end of the risk, what they're looking for are your RCTs. And when we're assessing against the evidence standard framework, what we're looking at is not just have they got the RCT, but who was it effective for, at what point in the pathway. And I just wanted to pick up on a point that you made about maybe 5 out of every 10 people can benefit from a technology. It may be that that technology was only aiming to help those 5 people, but that there's another technology that can help the other 5 people. And that's reasonable. So if a technology is there to support mild anxiety and we give it to everybody with a mental health condition, it's likely that it's only going to help a small proportion of everybody. So we have to think about these technologies, again, in the same way we think about pharmaceutical interventions. And then the final thing that I just wanted to pick up on the interoperability, you're absolutely right. That is where everybody is striving to get to. Everybody wants to have data that interoperates. However, I've travelled the world and I am yet to find anybody on the planet that's achieved it at scale and pace, particularly when we're talking about patient-facing interventions. And so we're on that journey, and part of the reason is because electronic health records are not set up to receive this data. However, I wanted to propose a different offer, which is that the patient holds the data, or the person. So in another health condition area, type 1 diabetes, I live with that condition. I have droves of data about my own condition, and when I go and see my clinicians, I can share my data. Of course, the ideal would be that I could share it interoperably, but until that day, let's not stop what we're doing.
Okay, I was going to open it a bit for, we could grab it on here for a long time, but has anybody got any questions for this? Okay, good. Not 2 people so far. Okay.
I'll stay sat down if that's all right. Dimitri Varsamis from UiPath, an intelligent automation company, but really with my 17 years of NHS experience, it's hard to let go. Thinking, it's easy enough to say, well, somebody needs to pay for it. My question to yourselves is, in these lean times that we're in, where the national budgets for tech and innovation get halved overnight from 2 billion to 1, and then another 300 million out of the budget a couple of weeks ago, are local decision makers and funders and budget holders, are they finding it all a little bit too risky to invest in something that then they just won't have any money coming from the top for ongoing spending?
Do you want me to try and ask that? Okay. One of the issues is that, so the answer is probably not. What is difficult is if you are commissioning a service, because digital therapies have not been nested into these providers, you're commissioning a service that says, we want you to do this. We want you to see, in my instance, I work in child and adolescent mental health. Everyone is very interested in how do we do ADHD assessment? How do we get better ADHD assessment? If I, as a provider, are then basically procured by a ICB to deliver ADHD services, and then a digital technology sort of comes along on the periphery and says, oh, and by the way, we could also help with maybe some assessment around expressed emotion within the family. As a commissioner, I don't have the headspace to be able to think about, because that's outside the kind of core remit of what I'm commissioning. And as a provider, I'm saying also, I haven't got, you've contracted me to do ADHD services. I can't then think a little bit about bringing in this other innovative technology, because that's not what I'm being directly commissioned for. So that's what I'm sort of saying, is that if you collaborate with providers and you say, in discussions with commissioners, we can offer ADHD services, but also we think expressed emotion is crucial for the delivery of these, of providing efficiencies, and being able to understand who recovers better, and then being able to have quite an augmented care pathway. And that will be a world-leading care pathway. Commission us to do that, then you're more likely to get an in. So I don't think there's absolutely a lack of money. It's sometimes it's the lack of the collaborative agreements between providers that actually then put single business cases to ICBs.
Okay, I'm going to hand over because there's another question just over here.
Hi. You've mentioned the prescription and reimbursement pathways. And I'm wondering, with a lot of legislation being created in countries like Germany and France, where they have the standard frameworks, is there something like this planned or envisioned for the UK? Because that would make life of all the participants easier.
So just to give everybody a bit of background, in Germany, probably about 2.5 years ago, the Ministry of Health set the equivalent of what's called the DTAC here, so the criteria to assess technology. Theirs is called the DIGA. And what they also passed was a law that said if a doctor prescribes a DIGA-compliant technology, that the health insurer has to pay for that product. Sounds incredible, and they have been really pioneering. And France, as you mentioned, have looked at that model, and they're looking to replicate something similar. However, what I'm just going to do is just share with you where that DIGA process is at currently. 4 of the DIGA products have gone bust, and they are now suing the Ministry of Health. So we have to learn some lessons from that. They've been really pioneering, but what they didn't do was they didn't train the workforce, to Johnny's point, to receive the technology and embed the technology into clinical practice. There was no prescription infrastructure, so doctors were having to write 4 or 5 letters to prescribe the technology. So very few prescriptions happened, and what that meant was the ROI wasn't there. So the value of the per product prescription reduced in most cases by about half, and those businesses had to give back 50% of the funding. Now, so what can we learn from that? What we can learn is that we absolutely need to have a workforce that's ready to receive and embed these technologies, and also prescribe them through a system in the same way we do with drugs. So your question about what's going to happen here, I know that NHS England are working hard to look at this. They're currently doing a whole round of round tables with industry, the NHS, etc., a whole load of stakeholders to work out what does that look like here. But I'd also say that Scotland, Wales and Ireland are also looking at this in similar streams. So don't forget the UK isn't just England, it's 4 nations.
Okay, thanks. And one more question, brief question, if there is one, or we can rub it on again. When people put their hand up to scratch their head, I think they're putting a hand up to ask a question. Okay.
Thanks. What you said really resonated with me because I'm working in Northwest London, trying to get more digital tech into CAMS or all mental health services. What you said about workforce, at a time where we don't have enough staff and the staff are really burnt out, how can we do what you're saying to get them ready?
Okay, I'll just start doing that because given that I've done some of the work on facilitators and improvement, one of the issues was resources and how we provide those, get the workforce to be ready. And one of the ways that I've done it, because I have a therapist-supported service, a digital service, I've just produced online training. I've worked out what level of person, which isn't the experienced, highly trained professional, to provide this. And to be able, and you need to think about that, and you only think about it because you've talked to clinicians about what is necessary to go into that service. So it's really important that we do that training and evaluate that training. In fact, I think Romina is somewhere in the audience whose paper on the evaluation came out yesterday. Johnny.
Yeah, I think if you can save time, if you can work out how you're saving time somehow, and we developed a product which is now it's all across our CAM services in South London, but we basically tried to reduce clinical input into that product. I mean, very much part of the co-design, the setup. Remunerate your people when they come in and do co-design. See if you can offer something and as an incentive so they get engaged properly and feel responsible. But if you can work out and it just needs to be your first one, and then you're starting to get people to engage in a product and then start to sort of segue from that. But you've got to demonstrate how you're saving time, as you'll be fully aware.
I just wanted to add, it's not easy, it's a journey, and if you think about it like a normal distribution curve, what you'll see is your really excited healthcare professionals will want to do this, but your challenge will be getting over the average person. Now, how do you do that? Well, one of the things that we do when we're working with our partners is we've created something called the Digital Health Academy, which is 5-minute segments that you can access on your phone, and it's CPD accredited. So you can do it when you're on the bus, you can do it when you're cooking dinner, or you can do it in between patients. We always have to supplement that with change management, so 16-week cycles of change. But just to reflect on something, any software that we've been introduced to as healthcare professionals, we've had to be trained in it. And I'm probably older than most people in this room, but I remember going to training on how to send an email and thinking that was pure magic for a half a day. So I just wanted to share that we have been here before. It's not easy. I remember when electronic health records, when we were scanning in all the records. So we can do it, but just eat the elephant one spoonful at a time.
Okay, I just want to thank everybody because we're definitely out of time now, moving on to the next session. Okay, thanks Liz and Johnny.
Thank you very much.